Now go back to our case. As Amit suggested, surgery in the beginning, and then was an RFA. But Riyad, from your perspective, and we'll talk about surgery versus RFA. What's your perspective? What's the data shows in regard to surgery and RFA?
So that's obviously a controversial topic. There are several lines of thought when you think about resection versus RFA. Obviously, RFA has the advantage of being much less sort of invasive. It's done faster. The recovery's simpler. And when you look at resection, it's a much more involved procedure. There's a surgical complication rate, and of course, most of these patients are going to develop some sort of recurrence at some point. So I think it depends on the audience you're looking for. In terms of this case, I like the ablation option when he recurred. This is textbook, 2-centimeter lesion, probably had washout, and based on imaging criteria. And ablation now has become sort of very well tolerated, very well done with reproducible outcomes. So I think this person had the right treatment at the right time.
Fair enough. But I will challenge you here, Amit, on one thing. The patient had an initial diagnosis, resectable disease, recurred, and there is data in the literature, among which the data that came out of Memorial when Yumin Fong was with us, is that by definition, recurrence is stage 4 disease. Your thoughts?
Yeah, I think that, the recurrence after resection clearly implies that he has a quote-unquote worse tumor biology. And I think you have to be aggressive in terms of management at that time. I actually think that when he had recurrence, he had small disease and he underwent ablation. I think the bigger thing is that there's also data for salvage transplant at that time. And honestly, if this patient was seen at our center, we would have listed him for transplant when he had that recurrence with this 2-centimeter lesion. We would have treated him with local regional therapy, but we would have listed him for transplant at that time. Now, he clearly has, what really showed to be bad tumor biology, because even within a year, he had metastatic disease. And so, you can argue that transplant in this patient would have been the wrong thing to do. And this patient's course, once again, more suggested what you're suggesting, that he was heading down that route towards systemic disease.
Fair enough. And along that line, if anything, for our colleagues, the key elements over here is to really realize what are the criteria that really make a patient amenable for a resection or RFA or transplant. And these are the 3 curative therapies that we can offer. In regard to resection, it really becomes a decision-making done by the surgeons. Definitely, surgeons will be mostly concerned about vascular invasion and metastatic disease. In regard to RFA, there's a kind of like limit in regard to size. And usually things that are really rather very small, in the like 2 centimeter, are probably amenable to a RFA. We kind of have seen the data showing that the 2 entities being surgery versus RFA are equivalent in regard to survival outcome, even though sometimes the recurrence-free survival might be a little bit better on the surgical component. But again, as Riyad said, this is a little bit debatable per se. Now, in regard to transplant, we didn't talk much about that, but if anything, the Mazzaferro criteria or the Milan criteria remain really the basic ones that we go by, which is 1 lesion less than 5 centimeter, 3 lesions, each one of them less than 1 centimeter, no vascular invasion, no metastatic disease. Now, from there, there's a lot of diversion in regard to who can be transplanted and if it's really amenable per se. And this is bringing me back to Riyad for one thing. I would be curious. Sometimes we hear about patients with great liver functionality, like our patient over here that Amit just mentioned. And despite that, usually the potential for a transplant will be based on liver function with limited disease. But even with the great liver functionality here, and let's assume that the criteria are within the Milan criteria, why people might argue that this is a great patient to be transplanted as well?
Well, this is the kind of patient, if they have chronic liver disease, ultimately that's going to be the chance for the best long-term survival. So, and those are patients that are selected out by the hepatology team and of course validated by the transplant surgical team. So I think the best long-term outcome where you're dealing with not only the tumor but also the background liver abnormality is probably the best thing. I did want to add something, Ghassan, to the RFA discussion, because I think it's one of the things that sometimes we forget. And yes, small lesions, like you mentioned, are ablatable, but the location of the lesion is also an important narrative. And that's why sometimes lesions are very difficult to ablate because they abut the bile duct or the veins, for example, or they're difficult to access or difficult to see under ultrasound. And that's where the stage migration concept comes in. And so if you can't ablate small tumors, then you migrate to another local regional therapy like an embolization of some sort. But that needs to be discussed because that's how we're embolizing a lot of small tumors as well, because they could be ablated, but it's very difficult based on their location. It's just something I wanted to add to the audience.
No, that's excellent point.